We put a ton of trust in our doctors, right? But have you ever really stopped to think about how we decide they're truly ready for that job? How do we actually measure what makes a good doctor? It's a question that goes way beyond just passing a big exam. Okay, let's get into it. You know the image, a student, head down, filling in bubbles on a multiple choice test. And we kind of assume that if they know all the facts, they can do the job. But here's the thing. Is knowing the 5 causes of something the same as skillfully diagnosing a real anxious patient who actually has it? That's the huge question we're going to tackle today. So to really get to the heart of this, we need to understand what we're trying to measure. And the key term here is clinical competence. Trust me, it's so much more than just being book smart. Just look at this definition. It's this whole mix of knowledge, sure, but also communication, technical skills, reasoning, even emotions and values. It's not just about what a doctor knows, it's about what they actually do, day in and day out for their patients. It's a really complex thing, which means you're going to need more than just one tool to measure it. So here's the game plan for this explainer. We're going to start with a really cool framework called the Competence Pyramid. Then we'll jump into the shows how arena, which is all about simulated assessment. We'll climb all the way to the top with the ultimate test, the does. After that, we'll talk about a big shift in thinking called assessment for learning. And finally, we'll see how all these pieces fit together to build the full picture. All right, so our guide for this whole discussion is a concept called Miller's Pyramid. Honestly, the best way to think about it is like a ladder. To really understand a doctor's ability, you have to climb up from the basic knowledge at the bottom all the way to their actual performance at the very top. So here's how it breaks down. At the very bottom, you've got knows. This is just pure factual knowledge, the kind of stuff you test with a multiple choice exam. Step up a level, and you get to knows how. This is about applying that knowledge, maybe in a written case study. But the real leap happens when we get to shows how. This is where we're asking, okay, can you actually show me you can do the skill? And then at the very peak, the ultimate goal is does. What does this person actually do day in and day out in a real clinic with real patients? And this quote just nails it. The higher up that pyramid we go with our assessments, the closer we get to what really truly matters, how a doctor is going to perform in the real world. It's all about bringing professional authenticity to how we evaluate them. It's the difference between potential and actual practice. So let's climb up to that third level of the pyramid, the shows how arena. This is where assessment starts to get really active. We're not asking what a student knows anymore. Now we're watching what they can do, even if it's in a controlled, simulated world. And the main tool for this level is the OSCE. That stands for Objective Structured Clinical Examination. This thing was a huge game changer in medical education, designed specifically to test hands-on skills in a really standardized and fair way. So how does it actually work? Well, imagine a big room set up with a circuit of different stations. At one station, a student might get 8 minutes to take a medical history from an actor who's playing a patient. At the next, they might have to suture a wound on a realistic model. And at every single station, there's an examiner with a detailed checklist scoring their performance. Because every student does the exact same tasks, it's a super fair way to compare their practical skills. And this table really lays out why it's so different from the old way. The traditional long case exam involved a student seeing just one patient. The problem? Well, the difficulty of that one case could be all over the place, and it only tests a tiny sliver of their knowledge. The OSCE, on the other hand, lets you test a whole range of skills across many different scenarios. The focus shifts from just reporting what you found to actually doing the task. And because it's so standardized, its reliability is way, way higher. But even the best simulation isn't the real world. And that brings us to the very top of the pyramid, the does level. This is it. This is the ultimate test, assessing how a doctor performs not in an exam hall, but in the messy, unpredictable world of their actual day-to-day job. The key to this is something called workplace-based assessment, or WPBA. This is not some special exam day. This is assessment that's woven right into the workday. It's all about observing a trainee during their normal routine, on the ward, in the clinic, wherever they're working. And there's a whole toolkit for this. For example, a senior doctor might use a mini-sex to watch a quick 15-minute patient encounter and give feedback. With DOPS, they directly observe a trainee doing a specific procedure, like putting in an IV. A case-based discussion digs into their clinical reasoning after they've seen a patient. And multi-source feedback is amazing. It gathers input from everyone, nurses, colleagues, even the patients themselves. Each tool gives you a different snapshot of their performance. Now, all of this leads to a really fundamental shift in how we think about testing. For a long time, assessment was just about judgment, pass or fail. But modern methods, especially WPBA, are built on a totally different idea: assessment for learning. Just look at this comparison. On one hand, you have assessment of learning. Think of that as the big final exam. It's high stakes, and its whole purpose is to give you a grade. But on the other hand, you have assessment for learning. This has a completely different goal. Its purpose is to give you feedback so you can get better. It's a low-stakes developmental tool. It's really the difference between a final recital and a coaching session with your instructor. And this right here is the magic ingredient. See, just giving someone feedback isn't enough. The whole point of this kind of formative assessment is to kickstart a cycle of reflection and action. The trainee has to actually take that feedback, think about it, and then use it to make a plan to improve. It completely changes assessment from being a judgment to being a catalyst for real growth.
So, we've climbed the pyramid, we've shifted our entire philosophy, now let's put it all together. Because the single biggest takeaway here is this: no one assessment tool is perfect. The best systems build a complete, detailed picture using lots of different tools.
A really modern assessment program does it all. It uses written tests for the nose level, OSCEs for the shows how level, and workplace-based assessments for the all-important does level. It cleverly mixes those high-stakes final decisions with low-stakes feedback for improvement. It's not based on one observation, it's based on many observations by many different people over a long period of time. And then tools like portfolios pull all that evidence together, creating this rich, holistic view of a doctor's journey to becoming competent. Which brings us to a final thought. There's a famous saying in education: assessment drives learning. Basically, whatever we choose to test is what students will focus on learning. So think about it. As we move from just testing facts to assessing real-world skills, communication, and on-the-job performance, what does that mean for the next generation of doctors? If we assess for competence in this bigger, more complete way, we're not just making better test takers, we're actively shaping more competent, more reflective, and ultimately better doctors for all of us.